assumption that predominantly you guys, any exposure you've had to capnography has been time-based capnography, where you're measuring in tidal CO2 versus time. Your typical one we covered last time, those slides. Yeah? Volumetric capnography is a whole different beast. And in actuality, I think it's probably a better use of the technology than traditional one. This is what the graphic would look like under a volume-based capnogram, and it does have different phases, not quite the same as the phases on a time-based capnography, as we'll find. And there's a couple of other things that we're looking at here. What you're really looking at is plotting the exhaled CO2 against tidal volume, or against volume that's exhaled. So you not only have your infrared CO2 sensor, you also have a flow sensor that's monitoring expiratory flow. So I can correlate at what volume do I start seeing dead space happen, and so on and so forth. In fact, there's something called effective tidal volume. That's basically saying how much of your tidal volume are you actually utilizing that's benefiting the patient. It's actually getting to the alveolus. So it's fractional concentration, and it could be partial pressure, whichever, against volume. And there you can see I end up having an infrared capnograph. I end up having a pressure differential pneumatic measuring flow, and I'm able to display those various areas, as we'll find. So there's a bunch of numbers here. Let's go through what they represent. The first part is looking at dead space. So that phase 1 is a dead space measurement. Then I have a slope of a line that's rising at some angle. And then I have it plateauing to another angle, with my end tidal value being the very end of that graph. So phase 1 is looking at dead space. That's this portion on the left-hand side. And if I'm seeing a prolonged length there, that means that I have more dead space in the system that I would anticipate to have. And there might be some rebreathing there. Notice I can also quantify the volume of the dead space that I'm measuring. So I can state how much anatomic dead space I anticipate or think I should have. And if that value is larger than that, then maybe there's some other mechanical dead space that is thrown in there. Phase 2 is this vertical rise, that green line there, number 3. So this is the transition from upper airways to lower airways. So as we're emptying, we're flushing out whatever CO2 might be in the upper airways and getting down to more of a peripheral portion. And this line, this portion of that line, or this portion of that curve, that line, that slope should be very steep. This is representative of perfusion. We always think of CO2 as being ventilation dependent, huge perfusion dependence also. So if we're not seeing adequate perfusion, the slope of that line, as we'll see, will start becoming more towards the horizontal axis. I got some examples of these as we go through it. Phase 3 then represents alveolar gas exchange, and this is showing the distribution of the gas as the patient is exhaling. And what you want to see here is a flat portion. Any steepness to this is implying that there's a maldistribution of gas elimination. So in other words, certain alveoli are emptying prior to other ones. And at the very end, we mentioned about the end-tidal CO2. And notice that this entire area under the curve here, all of this portion here, is CO2 production. So you're quantifying how much CO2 is being exhaled. So we can actually measure CO2 production, where prior we didn't have that ability to do it, now we do. Because I'm not only measuring the exhaled CO2, I'm measuring the volume of gas that is being exhaled also. So there's our curve and our two lines. Another graphic just showing kind of the first part is dead space, second part is perfusion, third part is gas distribution. Kind of get an idea of it. Whenever I see an increase in phase one, I'm looking at an increase in dead space for some reason, be it mechanical, be it anatomic. Well, anatomic wouldn't be increased, but the mechanical certainly would. Phase two, you're going to look for that slope reducing, so it's not as steep. That would tell me that I have a reduction in perfusion. In phase three, we're going to look towards maldistribution of gas. Okay. I want to pay attention to that. So let's take it to phase one. You can see the distance here is very small, and I can quantify it if I'm looking at a tidal volume that's maybe 25, 30 cc's. And you can see here it's much further out. So I have a much more significant dead space volume that is there. Everybody see that? Phase two, we're looking for how steep that line is. Assuming we have a stable minute ventilation, it could be because my level of PEEP was increased and I'm seeing an inoptimal PEEP where I'm having venous return being impaired, cardiac output falling, or it may be something where I need to address the hemodynamic status. Do I have something where the contractility has been impaired and cardiac output is poor? Has afterload been increased and it's difficult for the left ventricle to empty? And this is what it would look like, where my baseline is there in blue, and I see the slope going more towards the horizontal axis. That's a sign that perfusion has been impaired, and I need to address it in some fashion. Okay. There's a pretty dramatic drop. You can see the darkened one is the pre, if you will. And then you can see there's a significant drop both in entitled CO2, which should give you a clue that there's a dead space situation going on, i.e. ventilation is exceeding perfusion. And also just the slope of that line has been dramatically changed. And this, by the way, is the screen on the NICO monitor, which is, to my knowledge, the only volumetric CO2 monitor out there. Phase three is basically we're looking for a flat line, and if we're seeing an increase or a total absence of it, we know we end up having some maldistribution. Again, taking a look at the optimal PEEP level. If we don't have enough PEEP, it's collapsing down. Or we have something like bronchospasm, or I'm having a non-uniform emptying because some areas are obstructed. Or is it something where you end up having something like a pneumothorax where I don't have any ventilation at all? And there you can see the steepness of the black line showing there's a change in the phase three slope, meaning that there's a maldistribution of emptying that is present. And on the one on the right, you can see there's virtually not even a phase three there. So what we're looking at here is this volume under the curve on the right being alveolar volume. The portion to the left is the dead space, and anything that's remaining is the exhale. Basically what they did is they took the distance of this line, this vertical line, sliced it in half, and considered everything to the right to be alveolar volume, everything to the left to being dead space volume. They're going to call this the effective tidal volume because that's the distance between the end of phase one and the end of phase three, which is what this is. phase one again being dead space, the rest being what is truly coming in contact, or in theory at least, with alveolar volume. So on a breath-by-breath basis, we can see how the CO2 is being emptied. And calculating the volume, the area under that, will end up giving us the VCO2 that is present. And it will continually display this process. In theory, it's the same as CO2 production. Technically, it's CO2 eliminated. The assumption being is that all the CO2 that is being produced is ultimately eliminated through a tidal breath. It also takes into account transportation, so basically the perfusion involved. Sometimes there's CO2 that is converted into other structures that need to be eliminated. And we can use this value, the CO2 elimination, along with the alveolar minute volume to assess for weaning. The area above that curve, if I measure the carbon dioxide level inside the bloodstream, so if I measure my PaCO2 compared to my end tidal, all of this additional area above is alveolar dead space. Now, under ordinary conditions, the difference between end tidal and arterial should be very small, implying that there's a very minimal amount of alveolar dead space. Alveolar dead space is defined how? Great. Areas of ventilation where there's no perfusion. So it could be a relative dead space where I have some perfusion, but just it's not matching the amount of ventilation you end up having. This is typically what we would see in zone 1 of west, that at the apices you end up having ventilation occurring, but the perfusion is less involved. This will give us that area of Y here, that's the letter Y, not WHY, is giving us the same exact information on a breath-by-breath basis. So this is just showing how they're calculating physiological dead space. If you have that arterial CO2 value, which is again what this value up here would represent, then I can go ahead and calculate out, because I do have a mean expired CO2 now, I can truly go ahead and measure the Ingoff modification of the Bohr equation, getting my physiological dead space. And you can quantify, because I have volume along the x-axis, I can quantify exactly how much alveolar ventilation I end up having. So how we're going to use this to assess work during a breathing trial, this is what you expect to end up seeing. The top graph shows shows minute ventilation. The second one down shows CO2 production or CO2 elimination. The lighter portions of the upper graph show that how much is mechanical. The bottom portion shows how much is spontaneous. This is using an SIMV approach to weaning somebody, where I'm gradually reducing the support from the ventilator. So the so the spontaneous portion of the total minute ventilation should go up. And what you should see is that the amount of CO2 elimination should go up also, because I'm not having an ineffective ventilation happening. Can you see that? I'm reducing the portion of the minute volume that is contributed by the machine, increasing the amount that the patient is doing. And the amount of CO2 that's eliminated gets a little bit larger as we go along. Why does the CO2 elimination get larger? Okay, so that would improve cardiac output. How would that improve? Why would that yield a larger CO2 production or CO2 elimination? I'm going to use those two words interchangeably, even though they're not. Does spontaneous breathing have a higher work associated with, a higher creation of energy? So you're probably going to see some increase, not significant, but you're going to see some, okay? Now, the bottom one, we have a situation where you end up having, again, we're trying to do a weaning trial, trying to lower the SI and V rate. We get to about this point, and we notice that this CO2 elimination goes down. It would go down simply because I have ineffective ventilation. I have a shift from a relatively normal dead space volume to one where I'm breathing very shallow. As I breathe shallow, I'm breathing close to my dead space, my anatomic dead space. There's not effective alveolar volumes. CO2 elimination can't happen. So even though there's a work of breathing that's increased, the patient can't exhale that extra CO2. So what would end up happening on a blood gas to them? Yeah, they get acidotic, they get hypercarbic. That's what we end up seeing. They can't eliminate the CO2 because they can't do an effective tidal volume. If I'm breathing like a spaniel, I'm not going to get anywhere. Yes. My guess is, I don't know that for a fact, but I just logically, that's what I would think. This total thing is minute ventilation.
Okay.
And it's just showing what portion of that is the machine and the patient. Okay? So just a tool you can use to see, even before their blood gases would become profoundly acidotic, I already see that this process is happening. I'm already watching the failure happen before my eyes.
So the breathing like a spaniel, you mean, as in terms of not frequency, but being shallow? Or both?
And probably both, yeah. It's probably a rapid, shallow breathing pattern.
And so that would be considered hyperventilation because
No. Their CO2 is going up, not going down. It's hypoventilation, if anything, specifically alveolar hypoventilation. Even though their tidal volume, basically what ends up happening in most patients is their tidal volume gets smaller and smaller and smaller, and when you start approaching your anatomic dead space, you're not clearing anything. You're not effectively ventilating. This was a study that was done looking at those values to look at recruitment for somebody who's suffering from profound hypoxemia. So they had a cabbage patient that basically developed maybe some ARDS or at least some, what we used to call acute lung injury in the process. 72-year-old cabbage being mechanically ventilated. He started developing some drops in saturations upon arrival, shortly after arrival into the ICU. They tried to increase the FiO2, which of course didn't work. They tried to increase the PEEP, which didn't see a whole lot of other processes going on. So they said, hey, let's re-recruit some alveoli in some fashion. So what they did is they gradually increased the PEEP level. I can't see that. 12, 14, 16, 18, 20 of PEEP. Yowza. Okay. And they did this every 10 minutes, and they watched the alveolar volume, the VCO2, and the SpO2. And here we can see our VCO2. Here we can see our alveolar volume. So we didn't have any drop in CO2 elimination, which is good, which means you're still perfusing alveoli that are functional. But we start seeing that this line develops a trend. As you start increasing alveolar volume, you start having oxygenation improve. Why? Because now I have alveoli that are participating, where previously they weren't. So they saw that at about 16 they had their optimal level, didn't get much better above 20. So they ended up, or they're starting to see recruitment at 16, but the guy actually got a little bit better at 20, so that's where they left it. That's right. Your saturation here is at 98%, which is pretty good saturation at that point. So watching that alveolar volume tells me how much recruitment I have. I would love to see this with APRVs. I think it'd be so cool to see the alveoli popping open. And again, the VCO2 not changing shows that the VQ status was stable. SpO2 did not show any improvement until we got to that best PEEP level. So they were able to identify where the best PEEP was, looking at both the alveolar tidal volume, basically the alveolar volume, and the VCO2. Remembering optimal PEEP, you guys have heard about that before, right? Yeah. As you increase overdistension, you increase dead space by reducing perfusion. And I can look at that phase 1 to know if my dead space fraction is improving. I can also watch the slope of that line in phase 2 to tell if I'm impeding perfusion. So again, it's another tool you can use to determine an optimal PEEP level. And here you can end up seeing that as I go up on my PEEP, I end up having improved ventilation at some point, and then some degradation after that. Here's another example of using the same kind of a thing. Head injury, rib fractures, put it into a coma, developed an acute lung injury. They tried to maximize improvement, lung recruitment, and determine an optimal PEEP. And they're using, again, the same technology involved. And you can see this as they go up on the PEEP. This is the first line. They keep seeing a stabilization until they drop off. This means that I'm having a bad spot. Go back to that lower level of PEEP. VCO2 comes back up. Alveolar volume remains stable. I have basically an optimal PEEP utilization as a mechanism.
So that's what people call the drop VCO2?
Mm-hmm. Because I can't eliminate it because I can't bring the CO2 back because perfusion's impaired.
Oh.
Right?
Okay.
So alveolar volume should end up seeing an increase after the optimal PEEP because I'm recruiting. And VCO2 is going to decrease when I go over, but once I come back to that lower level, it should recover, and I should see that I'm not seeing any compromise of pulmonary perfusion. Looking at the slope of phase 3 here, you can see that on day 1 it's a steep portion of that curve, meaning a maldistribution of gas elimination. It's not, the lung isn't emptying equally. Once I bronchodilate them, you can see it's a much more stable line in the process. So the graphs show exhaled CO2 versus volume. That's what that line is demonstrating there. And you can see that on the bottom I have somebody who has severe ARDS, because there's a very small alveolar ventilation, where somebody who is much more healthy has a much larger amount of gas that is being ventilating the alveolus. Same rough tidal volume, but there's a far bigger dead space on the bottom one. Other uses of capnography, identifying pulmonary embolism. We know it's a pretty significant cause of death. And there was a study that was done that by monitoring the VDVT, they were able to identify patients who had a pulmonary embolus earlier on in their course and had a better success in management. It's kind of hard to read, but it's basically showing where this would be this B here is somebody with a pulmonary embolus. This is somebody who has a normal. You can see there's that maldistribution of ventilation there, and a big dead space fraction. Lastly, I won't ask you anything on this because I don't know of anyone who's actually using it, but it's a cool technology. How many people have ever heard of the Fick equation for measurement of cardiac output? Anybody? I thought not. I never mention it because it's bad enough that we got the other ones. But if I measure the oxygen consumption and I divide it by the arterial to venous oxygen content difference, I can actually get a quantification of cardiac output. This is actually the gold standard that we compare thermodilution and now all the other styles of cardiac output to. This is the bench that we would use. It's based on the Fick principle. Yes, the same Fick guy who had Fick's law. And we can actually substitute CO2 instead of O2 using the same exact equation. And that's what this process does, is you have this little system set up where I adjusted dead space and create some hyperventilation in the process. And in essence, if I look at the change in the CO2 that's eliminated and the change in the end-tidal value, trust me on the equations here, it'll actually give us a cardiac output. So it's a way to do non-invasive cardiac output on a patient who's being mechanically ventilated. Pretty neat idea. The only problem is that you're rebreathing some CO2 during the measurement of this, and some patients, especially patients with head trauma, that can be a bad thing to do because you end up increasing ICP in the process. So this is just basically showing some measurements of cardiac output in the process during this rebreathing period here in the center. You can see the rise in end-tidal CO2. They can quantify that and be able to identify what the amount of perfusion is. So no questions on that, I promise.
Can you just slide about partial breathing method?
Lastly, I just want to make some mentions about other things that we've used capnography for. Apnea testing during brain death studies. It's a very sensitive index that'll pick up on any movement within the airway itself. So if they're seeing the patient have the spontaneous effort, it'll pick up on it. Evaluating diabetic ketoacidosis in children. No one likes to get serial blood gases, so I can use an end-tidal CO2. And they found that patients, if their end-tidal CO2 was above 30, they did not have diabetic ketoacidosis. This one was very interesting. This is an old study back in 2007, but I think it still holds promise. Patients who had an elevated VDVT early in the course of their ARDS had poorer mortality. Interesting. So somebody who basically had areas that were underperfused had poorer outcomes. So take it for what it's worth. I think that's one that should be doing more research on. And then we talked about what's PCA? Patient-controlled analgesia. Give me my drugs. I push a button and it's hooked up to a morphine pump. Problem is that we usually monitor these people with pulse oximetry. Argument could be made we should be monitoring them with end-tidal CO2. I think I made that point earlier about conscious sedation. American Society for Anesthesiology now recommends all patients receiving conscious sedation should be on end-tidal CO2. I think it's only fitting for today. Patricia.
So anything on the final from the last slide, any of that?
No. No.